How can this one?
Well, we operate on a baby who was born with a condition we call ectopia cordis. So that has to do with the development of the vital organs, in this case the heart, which when the baby was forming, formed outside the body. So the heart's outside the chest. And we knew this from fetal life. So our colleagues out in West Texas, Dr. Blanco and his colleagues, diagnosed this in a fetus. The child and mother were referred here to the Pavilion for Women for care, delivered here, transferred to our cardiac ICU. We evaluated the baby, and it looked like about a third of the heart was outside, so sitting just out to the world. And so in concert with our cardiac surgery team, our general surgery team led by Dr. Wesson, and our plastic surgery team led by Dr. Hollier, we did an operation to put the heart back inside the chest. So that was the goal. It's a really rare condition. It's not, thankfully, not something we see very frequently, and that's why we have, multidisciplinary teams like we do at Texas Children's to take care of these very unusual but critical problems.
And how did the surgery go?
Surgery went really well. The baby it was a bonus. The baby was very stable throughout, and she seems to have tolerated having the chest pulled together. And a little early to be definitive about her prognosis, but so far so good. We're very optimistic about the long-term prognosis for the child. She has otherwise a very functional heart, and the issues with the abnormalities of the body wall can be dealt with operations. The baby probably will have to have other operations in the future. Her sternum is about half formed, but these are things we can deal with. So we would be very hopeful about her long-term outlook. Well, having a team that deals with critical prenatal newborn or infants, so fetuses, getting the baby and the mother to the right place for delivery so that there's no missed opportunities in the delivery suite and the early care, and then being able to bring together a multidisciplinary team of children's specialists who deal with critically ill children every day. It's very rare to have that opportunity, and it's absolutely mandatory for the child to have the best outcome. So this is definitely not something that lends itself to an infrequent participant. This is where we need focused teams that take care of children. So that's what we really are blessed to have in Texas Children's in the Pavilion for Women, where we all come together. We talk about the children before they're born. So we had a lot of planning that went on. Everybody was ready and standing by, got the baby immediately to the ICU, evaluated, and then without really any delay to the operating room. Well, the fetal center at Texas Children's was critical in the management of this child. First of all, of course, the referring doctor elsewhere really needed to reach out to a coordinated center. So the fetal center has that structure where these diagnoses are made in advance. The team is coalesced, and the child is assessed as he or she is developing, and then a management plan is derived well in advance of the child's delivery. So this offers an enormous opportunity for optimizing the outcome, and the fetal center coordinates all that. Well, I guess for me personally, it's very gratifying to see this continuum of care extended to my home, which is in Midland, Odessa. That's where I grew up, and we're really thrilled to hear that the community of West Texas looks to Texas Children's Hospital and the Pavilion for Women as a resource. This is what we're here for, and we look forward to getting the child back home where she belongs.
Wow, it was an amazing experience for me, to operate with Dr. Ollier and Dr. Fraser together at doing this operation, which is on a very rare anomaly, an anomaly that often is very difficult to correct, but we made great progress this morning, and we got the heart covered, which was the #1 goal. So I feel very good about it.
And what was your role in the surgery?
Well, I was helping. Basically I was acting as an assistant for Dr. Fraser and for Dr. Ollier, but anything to do with an abdominal wall defect and the diaphragm, that's where my expertise would come in. But it turned out that this was almost exclusively a thoracic cardiac problem, not an abdominal problem. There was a little abnormality in the abdominal wall, but turned out that that's not really important at this stage of the game and should heal by itself. Well, you know, that's what Texas Children's can offer, you know, that almost nobody else in the region or in the state can bring to the table, you know, the expertise in all the various surgical disciplines at the highest level. I guess it sounds like I'm bragging a little bit, but you know, it's really great to be part of this team, and it was a very enjoyable experience to work with Dr. Ollier and Dr. Fraser. I guess you could put it this way, that I don't think there's anywhere else that they could have gone that offered anything more than we can offer them at Texas Children's. In my mind, there are two types of these ectopia cordis cases. The first type is the one where it's just a heart sticking out, but it's just a thoracic part. Sometimes there's an opening that extends right down to the umbilicus. And those ones are a lot easier to repair because the heart is partially covered with a membrane. And I've had several of those in the past, and they're really not too difficult. But the ones like this young little baby had today, where it's just mainly the heart sticking out, are often very, very difficult, and the survival outlook is not that great. But we made the biggest jump today by getting the heart covered with skin. Well, Dr. Fraser had his database open after the operation this morning, and there were just a handful of other cases in our database. So, I would imagine we see one every couple of years, something like that.
The procedure was one where, after an attempt at reducing the heart back into the chest, we needed to mobilize the surrounding soft tissue skin to cover the heart itself to get it back in. So my part of the procedure was primarily about making sure there was good enough skin or soft tissues to safely cover the heart and put it back inside the baby's body. Plastic surgery was involved by mobilizing all of the skin on the baby's chest to safely cover the heart, putting it back inside the body so that it could function normally again. The purpose of the cardiac procedure in Dr. Fraser's component was to create that space within the chest to try and put the heart back in. That was partially successful, so the heart moved back into the chest to some degree, but it still was partially outside of the baby's chest. So we needed to mobilize the skin, to elevate the skin and safely move it over the heart to make sure that it was safe. It's possible down the road, depending on how the baby does, the baby may need a secondary procedure to reconstruct that area, to put the heart back in a little bit. But I think what we'd all expect is that over time, that component of the heart will move further back in and be fully within the chest as the baby grows. In this day and age, medicine is so complex that no person can do everything anymore. So we're all good at a component area. The most important thing is to be able to mobilize all those specialists, particularly for difficult problems like this, to make sure everybody is hitting on all cylinders, doing what they do absolutely the best, and then turning it over to the next person for their component of the procedure. And I think it's nothing short of amazing that we would be able to take a child from far west Texas, bring that baby here, deliver it urgently, and then the very next day operate on the baby after getting all of the imaging tests needed